I'd like to welcome you to our webinar, Prepare Now or CMS Won't Pay Later, the impact of CMS's call letter to your revenue. My name is Sean Force and I'll be the moderator for today's discussion. During the presentation, all participants will be in a listen-only mode. We do, however, encourage you to ask questions during today's presentation. Please submit your questions using the questions window located on the right side of your screen. Type in your question, click send, and they'll be sent directly to a meeting organizer to queue for the Q&A session that we will host at the end of the hour. Should you encounter any technical difficulties during the webinar, please also utilize the questions window to describe your issue, and one of our support staff will follow up with you to troubleshoot. Most technical difficulties experienced are a result of poor connections and probably can be resolved on your end by exiting and rejoining the webinar. By the end of the hour, attendees will understand changes to the CMS-HCC risk adjustment model, changes in the Part C payment methodology, specific actions that you can take today to ensure success for your organization for calendar year or for payment year 2017. And that will include encounter data and star ratings best practices as well. We'll close the webinar by telling you a little bit about how our understanding influences what we do at Clear Vision and SCIO, and also have some time for Q&A. With that, I invite you to sit back, relax, and enjoy today's presentation. Our first speaker today will be Karen Bach. Karen brings more than 20 years of experience working in managed care. Karen is certified in healthcare compliance and has consulted with health plans nationwide in policy development, compliance, bid preparation, and compliance program development. She has focused on Medicare risk activities at Prudential, Blue Shield of California, and Clear Vision Information Systems prior to joining SCIO Health Analytics as Director of Compliance. Karen has managed compliance projects including CMS audit preparation and oversight, bid submissions, policy oversight, and HPMS monitoring and reporting activity. Karen will then be joined by Pam Klugman, who herself brings more than 25 years of experience in healthcare. Prior to joining the SCIO team, Pam was co-founder and chief products officer of Clear Vision Information Systems. Pam has served as manager of IT, Medicare revenue improvement and recovery for Blue Shield of California. She has also had roles as senior Medicare auditor for Blue Cross of California, reimbursement specialist for Cedars-Sinai Medical Center, and finance coordinator for Northridge Hospital. Pam has worked on many system development and data analysis projects, including the optimization of tracking and reporting of encounter and claims data using compiling submissions under CMS risk adjustment model. Pam also has been active in the industry collaboration effort, or ICE, since its inception in 1998, and has co-chaired the ICE Risk Adjustment Data Acquisition and Reporting, or RADAR, team for several years. Last and certainly not least is Susan Hedge, our VP of Operations with 30 years of experience in healthcare. Prior to joining Clear Vision, Sue worked at Blue Shield of California, where she led a team of systems analysts and programmers, overseeing day-to-day operations, analyzing workflow, and managing resources. She has extensive experience in business systems analysis, data security and control, and strategic computing. With a strong customer service orientation, Sue is instrumental in understanding the needs of our customers and ensuring that our production activities align with their requirements. She is currently overseeing all aspects of the quality initiatives, from coordination and selection each year to certification and implementation. Again, thank you all for joining us today. And with that, I'll step aside and hand things over to our panel. Karen?
Thank you, Sean. And good morning or good afternoon, everybody. Thank you again for joining us today. As you can see with our agenda, we're just going to go through some background. As you know, the main focus of this call is for the information that was pushed out through the 2017 call letter from CMS. So we're going to go over some of the key changes, how changes may impact your organization, and actions that you can take. So before we begin, let's just take a step back and consider what CMS is trying to accomplish. Many of you may be familiar with the CMS advance notice and the CMS call letter, so this may not be new to many of you. But basically, this graph helps to provide context for the decisions that CMS is making, which is basically focuses to improve the quality of care, promote alternative payment models, ensure the program integrity and beneficiary taxpayer value, and then obviously improve beneficiary experience. Okay, so following the theme from the previous slide, CMS call letter activities follow 4 major themes as they pretty much have throughout the past few years. Again, improving the bid review, decreasing costs, promoting creative benefit design, and improving beneficiary protections. So this slide here shows SCIO and ClearVision's perspective of what CMS is trying to accomplish. Medicare Advantage has been a success, and they're looking for ways to increase stability while promoting growth. So the key changes in this year's call letter intended to help organizations serving full dual eligible members. Okay. So here we're just showing you some of the highlights from the final notice for 2017. And we know that there's a lot to digest, from the call letter. And these are just some of the highlights that we've pulled out and that we wanted to focus on because it's related to risk adjustments and the star rating topics. So as you see here, the items that have the big stars next to it, that's where our focus is going to be today, which is with the CMS risk adjustment models for 2017. We're not going to go into a lot on the RX-HCC model because there really wasn't as much change to that as where we want to focus more on the CMS Part C model. Encounter data as a diagnosis source for 2017, one of the big hot topics. Changes in the Part C bonus quality payment methodology. And then last but not least, the star ratings 2017 and beyond. Okay, this information is just some of the other highlights that were pulled out. We're not going to spend a lot of time on these topics today. We just wanted to point them out because, from the industry, these are things that are going to be looking at going forward. So, it's just a little snippet of some additional information. But again, we wanted to focus more on the big changes and the impact from the risk adjustment models and the STAR program. Okay, so I am now going to hand it over to Ms. Pam.
Hi everybody, I hope everyone's having a great Tuesday. We're going to talk a bit about the Part C risk adjustment model, and we're going to talk about the easy things first. What is staying the same? So the HCC model 2014, also referred to as version 22, is not changing, and there was no mention of any changes so far for the home visits for the risk adjustment. And I believe that although CMS was trying to clamp down on this last year, there was a pushback. They didn't. We're at the end of an administration. I believe that moving forward, this is probably going to be off the table for changes in the near future. So CMS has come to realize that the home is the most underutilized source of care in the delivery system for seniors, and they don't want to get involved in making changes to that right now. So what is changing? Some of the items changing. The single community model is going from 1 segment to 6. They've updated the years to calibrate the models, and we will go through each of these in a little more detail. Disease interaction, the fact that the community risk scores will depend on the dual status in the payment month, which is a lot different than it used to be, and then that will tie back into the segmented community model. And the LTI risk scores will include an adjustment for Medicaid, so there'll no longer be a separate Medicaid bump, if you will. That's going to be built into the model. So the 7 community, how do I say this, segmentation. There's 7 full risk segments, institutional being the one that's staying the same, community being broken down into the 6 components you see here. The colors are indicating what direction that breakdown is going to affect payment, and also the proportion of the membership or enrollment that should be affected by these changes. So the non-duals, whether they be aged or disabled, should have a negative impact, and they're estimating 70% fit into the age and 7.6% into the non-dual disabled. Full benefits, are going up the highest, and the partial benefit duals, they'll have an impact, but a slight impact on the negative side. So the reason CMS is doing this, and you'll see this theme throughout this throughout the call letter, both risk and stars, and also through the presentation, is there's been a lot of comments within the industry that serving a dual population is more difficult. And so to more accurately predict expenditures in the upcoming years, CMS made a decision to segment the demographic portions of anyone in the community model. They did give us this information early on in the fall of 15 to solicit comments, and that they intended to correct two problems with this: the underpayment of the duals and the underpayment of those at the high cost end of the cost spectrum. And they believe they've done this with this change. They've, by adopting the 6 segments, they've aligned the financial incentives with the care prioritization. So I think plans would do well to follow CMS's lead and embrace the alignment by setting up campaigns to engage full duals and partial duals in disabled subgroups with blanketing intervention strategies. So for disease interactions, first of all, they recalibrated the model using updated fee-for-service data. And as mentioned earlier, the Medicaid factor will no longer be a separate add-on factor. It will be captured within the segmentation. In the community model, for all segments, they added an interaction with CHF and specified heart arrhythmia, and they also removed the sepsis and cardiorespiratory failure. And the disabled segments, you can see where they added some psych and substance abuse and the corresponding HCCs those referred to. Now, the interesting thing is that the monthly identification of where these people fit, because it's not going to be, oh, you were Medicaid or you were disabled, and so you're last year, so you're in this pool for the whole year. No, it's a monthly thing, and we all know how accurate those monthly the data fields coming from SSA. So CMS has not figured out the methodology to identify these, and they're going to be releasing that in the near future. And again, LTI will include a Medicaid factor based on the Medicaid status in the payment year, so that'll be incorporated into those payments, and no separate identification of Medicaid as an add-on will be there. The coding pattern and the normalization, the MA coding factor is going to be 5.66, and as you can see for the normalization factors, here's how it has gone through the last several years. And there was a note in the final call letter that there was an error in the draft, and they've corrected it in the final letter, and you can see the numbers here. So their estimate of the risk adjustment changes by going to segmentation is more accurate, and i.e. larger payments or higher payments for those that treat full duals. However, most organizations made a reduction based on their population composite of fulls to partials to regular agents. To be successful, you have to make sure that you reconcile each member's eligibility status monthly, because it is going to be a monthly benefit. And so once CMS submits their methodology, then we need, as an industry, to look at that methodology, find ways to reconcile that monthly, and make sure that if it's not correct in your enrollment, that we follow whatever procedure they give us so that we can get those accurate payments. There's a lot riding on getting this is correct at this point with the segmentation. And of course, make sure your documentation is sufficient to support the specificity needed for ICD-10. So just a little bit on the RX-HCC model. There are some model there are some changes, And what they are is they're using different information to calibrate the models. So for this payment year, they use 2012 diagnosis, and they use expenditures from PDE records. But moving forward, they're going to use 2013 fee-for-service and MAPD RAPS file diagnosis and the 14 expenditure data from PDE. So last year had larger changes, and they're trying to better align the benefit structure with payment year. The risk corridors are not changing, and they're going to remain at plus or minus 5% and 10% of the expected claim cost. And now what we're going to do is jump into everyone's favorite subject, which is encounter data as a diagnosis source. So they propose to use a blend of 50-50, and with all the comments, they decided to back that off to 25%. So we're going from a 90-10 blend to a 75-25 blend, although PACE organizations will still continue to have both data sources as additive as opposed to being blended. They think that the expanded role of healthcare payments will be better adjusted to reflect the population illness burden, and they're putting a greater emphasis on the accuracy and timeliness of encounter data for risk adjustment purposes. And they're going to do an incremental increase. Let me see here. They want to accurately track information from both data sources, and they're going to, there's a rapid growth in managed Medicaid, and there's a continued expansion of MA, and they think some of that is largely driven by the ACA. And as Karen mentioned earlier, the push is, the policymakers is toward healthcare cost and quality transparency. CMS feels they're going to get more transparency because they're going to have more data on with encounter data. As we know, it's a full 837 speculation around physician practice pattern analysis. Things like that are going to come with changing to encounter data as the source. They're going to gradually, with backing off and going into the 25%, they have actually stated that how the increases are going to go, and that by 2020, all risk adjustment information, be it calibration and or payment, will be on encounter data. And I want to make it really clear. While the trends they're saying are more encounter data, less errors, i.e. more accuracy, they're going to continue this weighting over time on encounter data, but they're also, and if you look at the FAQs on the filtering logic, there's some really good information in there. And what they're saying is that they intend eventually to base calibration and everything on MA-only data. So they're going to be using what our costs are. And if you think about it, fee-for-service costs are based on CPT codes. And we've said this many times in the past. The fee-for-service side of the house is really good at creating the best scenario for payment using CPT. They know how to bundle, they know how to unbundle, they know how to document for a more intensive office visit, things like that. We have to get really good at that, because should the day come when they calibrate on our data alone and we haven't mastered that whole CPT end of things, then the cost to treat a diagnosis or a condition, if you will, in the MA world will appear lower than the cost in the fee-for-service world, merely as a byproduct of our industry's lack of maturity in the whole CPT arena. So something that we need to focus on moving forward. Timeline for encounter data, 7/21/15, the initial filtering logic was published, and our assumptions were that we as an industry, or the health plans, we need to align that filtering logic with CMS's logic. The final filtering logic came out December 22nd, and in the FAQs, they said that and here, this is the FAQ. So the commenters asked whether they proposed encounter data filtering logic would apply to RAPs, and they requested explicit clarification for what years it would apply to, and it wouldn't be retroactive. CMS's response is really interesting, and it's somewhat lack of clarity, in my opinion. Plans should continue to follow the existing filtering rules for the RAPs, i.e. using specialty code-based filtering for professional data. So the filtering logic discussed in the memo, which was the memo from December 22nd, is HCPCS based and will only be used for identifying risk adjustment eligible diagnosis on encounters. So encounter data is not going to use specialty code, and the plans are expected to use it. So there's an inherent disconnect there between what's going to go in those doors. So variance report, and we have variance reports built into RevMax Pro, but the variance reports may show that you have a RAPS and you have a claim, but you don't have a filtered claim, and that could be 100% correct. So you'll get 90% of a payment in some cases, and you never get that extra 10%, and you'll sometimes get 10% of that payment and never the 90, and that could be correct. So the information we got back as an industry about what is filtering through using their filtering logic, the MA0004s, the initial ones came out on December 23rd. We've heard from this end, some clients are having issues with it, some are not, in terms of the validity of what's coming back on those 04 reports. If anyone has questions about theirs or needs some more research done, please give us a call. So the pros and cons of encounter data. We've already talked a little bit about this. Perceived benefits would be better support for the value-based payment models, because that's where we know CMS is going. Years ago, they had said they want to be known as a purchaser of quality health care as opposed to a payer of claims. And there's it better accounts for the difference in patient populations, so they're better able to stratify and look at costs. Again, keeping in mind their costs are only as accurate as our CPTs are for different segmentations of the population. The perceived challenges, the complexity and volume, have to pass the national CCI edits. Of course, a lot of them have been modified for our industry, but a great deal of them are still there. And then the looming possibility that they will calibrate and change base rates based on our encounter data only. Okay. So understanding how and where your data flows. Many providers and payers receive data electronically through vendors. Some are direct. If you're using a vendor, they can capture and transmit your data to health plans, but you might have data in your system that never makes it to your plan, and the plan may have information in their system that never makes it to the ultimate payer, CMS. So this shows you a chain of all the different hands that can touch your data on its way from the visit all the way to CMS. And if any of you remember playing telephone when you were a kid, rarely does data look the same at the end of the line as it did at the beginning of the line. And that's why it is imperative to understand the accuracy of your data. You have to have checks and balances in place as we move toward 100% encounter data. Make sure that you track the rejections by reason codes so they can be resolved and resubmitted and not kick out for the same thing. And this way you can recover dollars that might otherwise be lost. We all have to remember that the data we're sending, the encounter data, whether it's a payable or non-payable, in many cases on the West Coast here and throughout the Midwest, it's a non-payable encounter. And so we have to understand that the incentives to correct those are just the same as a payable claim, because not having that data make it through to the end point will cost you dollars. It may not cost you your dollars today, but when they calculate your payment tomorrow based on today's activity, it will surely cost you data or cost you dollars. So we have to make sure it makes its way all the way. You have to be able to see it from the point you sent the claim to your plan, to the plan to CMS, and back again. For EDPS, we have to submit all data. We have to work our 002 rejections. It's called, for those providers on the phone, it's a MA-002 is the first line of information where you can see what passed and what didn't pass the edits. And then there's a report called the MA-004, which said, okay, not only did they pass the edits, but they qualify for risk. So it's a two-step approach where RAPS, the filtering was done by the health plan. With encounter data, everything goes to CMS, and they decide what filters through based on the logic they released in December. And whether you do it yourself or you have a vendor do it for you, make sure you run your filtering logic. Make sure you compare what you get through in RAPS and what you get through in EDPS, understanding that that filtering logic is not necessarily the same. Know what your vendors are doing, what error reports are they getting. If you send it to an EDI vendor, they send it to the plan. What's making it all the way through? You could have sent them 1,000 and they sent 800, and then the plan only accepted 600. And now there's 40% of your data, and what happened to it? Okay? So real quickly, the bonus payments, just the fact that the quality bonus payments haven't changed. They're still tied to your star ratings. 3.5 or less get nothing. 4 or greater, you get 5%. There are qualifying counties that get a double bonus, and CMS has published a list of those. If you need to find that, don't know how to find it, let us know. We'll get it for you, or show you how to get it for yourself, actually. And although there's changes, the Affordable Care Act has changed that. The Affordable Care Act has required a full transition for the blending of the amounts in the base rate, and that transition started in 12 and will be complete in 17. So while there's not many changes in the methodology, Sue will be taking over now and going into the actual changes in the star ratings themselves. Sue?
All right. Hello, everyone. So CMS did address a member's socioeconomic and or disability status. There was industry pushback in this area. These folks actually cost more. So a number of MA organizations and PDP sponsors believed that enrollment of a high percentage of duals and or enrollees who receive a low income subsidy did limit their plan's ability to achieve high MA or Part D star ratings. So a data study was completed, and CMS announced that they would make a categorical adjustment index for those plans having these disproportionate populations. And as you can see, the impact is small, but CMS did listen and they responded favorably. So good news. With regard to penalty, good news for the plans under sanction. They will not automatically fall to a 1-star plan. CMS is going to reevaluate the impact of sanctions, audits, and civil money penalties on the star ratings. We are going to hear more from CMS on this in the fall of 2016. Although CMS will continue with termination of plans falling below 3 stars after 3 years, they did announce they might stay a termination, including notification to the beneficiaries, if the organization holding that poorly rated contract is prepared to consolidate the contract into a higher rated contract during the bid cycle for the upcoming plan year. Okay, so we've all seen this slide. In the first block, which are the new and revised status, we see 1 returning and 5 new 2017 display page measures. And we've got modifications, and 2 measures have been removed here. And so for next year, we've got lots of focus on Part C and Part D pain management in that potential new measures block there. You see that opioid use from all angles, you know, the high dosage, multiple prescribers and multiple pharmacies, multi-provider, high dosage. So that's the hot topic for next year. High pharmacy management, that's going to be where the focus is going to be. And then the last one, minimizing the antipsychotic drug use in persons with dementia. All right, so to wrap it up, organize your quality teams in such a manner that you're poised for optimum productivity. So you're covering all of your bases. STARS is a year-round effort. We should always be using our application tools to identify and close gaps and course correct wherever we need to. We must look forward to the new measures on the horizon. What is new on the display page? What's out there that needs our attention next year and proposed in future years? So I'm going to turn it back to Pam.
Okay, so what I'm going to do really briefly is the SCIO Health Analytics point of view, and what we, when you consider specific risk adjustment and quality measure challenges, when you think about that, there's a number of factors that can result in negative outcomes, and there's a whole list of things up there. So any one of these issues can have an impact on your risk adjustment factor as well as your quality metric scores. For example, we've worked with a health plan, and they had an issue with their data collection. The providers were sending data, but there was a gap between what was received by the plan and sent, what was received and what was sent by the plans to CMS. So adding extra data transparency exposed where the breakdown in the data stream was. And once that was fixed, there was $7 million in data that somebody had, but it never made it to CMS. And so finding the breakdown, having that transparency from the beginning to the end. So sort of like on telephone, if you had a script and you read that script to someone and then they handed the script to the next person who read it, at the end of the day, what's going to happen is how it started is how it ended. $7 million in revenue to a plan by applying that same sort of transparency. So working to improve your RAF score and your quality scores, they go hand in hand. So when you do both, you have an even greater impact on the quality of care and the revenue that you generate. So if you look at additional information, if you are looking from a revenue perspective, CMS calculates the scores each year for the enrollee, and it reflects the prediction of the beneficiary's likely costs based on their demographics and their health conditions, i.e. their diagnoses. The risk score determines the revenue and off to the plan, but often to the contracted providers as well. And so an accurate risk score can have a significant impact on your revenue, especially for those with multiple chronic conditions. It can increase your revenue by 2 to 3 times. In order to ensure continuity of care, it's also important for a provider to have an accurate view of all the health conditions. From a revenue perspective for the quality measures, plans and providers are continually incentivized to improve the quality of care provided to the members. That's why many programs have a bonus payment based on quality, as high as 5%, as we noted earlier. From a care perspective, the HEDIS STARS and P4P programs provide an objective way to evaluate the health plan and provider performance. And just a little note, when working at a plan, my area was in charge of risk adjustment, and we went to great lengths to make sure we got all the encounter data in, all the claims data in, and we were still doing RAPS files. But we were able to garner so much additional information on the risk side. The HEDIS scores for the plan went through the ceiling to the point where the HEDIS auditors came to us and said, what are you doing differently? When we explained our methodology for transparency between the plan and the provider for risk adjustment and tracking of the not only the quantity but the quality of information we got in encounter data, it affected both sides of the house. So while some areas have these items separately, it might be a good idea to think of them as sort of a seesaw, you know, except the seesaw goes up on both sides or down on both sides. So I guess that's not a really good example, but the reality is when you're trying to get additional quality data and large quantities of it, you can't help but improve any program at all that uses that data as a basis for a percentage or a decision or a change. So effective programs, they need to both work retrospectively and prospectively. So you have to look forward so you don't miss anything and, you know, hit somebody, but you also have to look backwards and make sure that there's nothing behind you that you forgot to take with you. You know, you're leaving one of your bags on the curb when you drive away from the airport is a good thing. So a small change, you know, a small change in score carries a significant impact. And so if you take a 45,000 member health plan, a $24 PMPM change can have a big effect on revenue. So from a prospective viewpoint, at the beginning of the year, both plans and providers want to create a suspect list of people they need to see or chart reviews they need to do to ensure that gaps are closed so that their revenue stream stays constant. For provider collaboration, coders are preparing member-specific pre-populated forms to give the physician so he or she is aware of the conditions that were previously diagnosed and any outstanding STARS measures. So if you can hand somebody something that says, this person had these chronic conditions last year and these conditions do not go away. So when they're in front of you, can you please assess whether these conditions are still relevant, if they still exist, and please document it. Oh, and by the way, this member fits into a population that will affect your HEDIS, STARS, or P4P, depending on what program, or all those programs. And while that member's at the point of service, this is where they fit into the denominator, if you will, i.e. they are eligible for all these tests, but they're numerator negative. They haven't had it yet, so can you please close these as well? So this helps. It helps with suspecting both retrospectively and prospectively. It helps with action planning. And if you're going to do a particular outreach and you need to measure those results, then you can use campaign modules to see how effective was that campaign on either your HEDIS changes or your risk changes. So what we talked about earlier, doing all these changes, all this proactive and retrospective work, you are the designer of your destiny, if you will. So you're making sure that you've planted the seeds for next year's revenue, and you're still harvesting the seeds that you planted last year that just didn't happen to sprout out. In other words, you're going to the charts that are most likely to have additional data for you. And in a 0.03% change in score, or $24 a month, 45,000 member plan, that's $12.9 million. A lot of money, over $1 million a month. And if you then take that to a provider that gets 35% of premium, it's still $4.5 million. So it doesn't take a lot of change to make a big improvement in your revenue. Some of the items that we have built into our software, our application, we have your risk factors, and we have a health plan summary. You're able to look at this at a glance, and it's updated every single month with all the data that's sent in, whether it be sent in from encounters or RAPs, and the comparisons are also in there. For the continuity of care reporting, this is a report looking at payment year 16, meaning these are 15 days of service where the data was available and submitted in previous years, but it wasn't submitted for last year. If you look in the top right where it says payment year, if you change that payment year to 2017, now you have a complete list of all the members you have that you need to see this year in order to ensure payment stays as robust as possible for next year. This is just a magnifying glass view of it, and then your STARS rating. We have STARS, we have HEDIS dashboard, P4P dashboards, and they show you the members, total members eligible for a measure, how many have met it, how many have not, with also a detailed breakdown into who they are. And additionally, we have pre-prepared forms, and this is just one of many, that shows where your deficiencies in your last date of service for your ICDs and HCCs, as well as your missing HEDIS and or STARS information. So just a little sample there of what's available to address all the changes. These are ongoing reporting, and the updates for the segmentation will be built in, so you'll be able to see how that affects your payments moving forward. Sean?
Great. Well, thank you, Karen, Pam, and Sue, for giving a great overview of the 2017 call letter, and a special appreciation for being right on schedule here for entering into our questions portion of the webinar. We have received, looks like, about 10, 15 questions already over the course of what we've presented so far, so we'll give folks a little bit of time to put some more in as well, and we do have one slide to sort of talk a little bit about an overview of CIO and our relationship with our friends at ClearVision.
So I just wanted to let everyone know we here at ClearVision are very excited and happy about our merger into the CIO Health Analytics family. It's actually the merging of two mission-driven and client-focused companies. So we complement each other's strengths. We have little to no overlap in services. Both of us are focused on using analytics and services to solve challenges faced by healthcare stakeholders across the continuum. Being part of CIO, we all now have a global reach, as they have over 900 employees, including some industry recognized thought leaders, statisticians, and health economics, as well as clinical and analytical specialists. We are the newest addition to their portfolio. And I think most of the people on the line know we were founded, ClearVision was founded in '06 in Southern California by myself and business partner Tom Peterson. We have worked at both plans provider groups and as CMS auditors. We have a national scope of clients and services that are used by health plans providers and ACOs. And combined with CIO, they have an international scope of clients that are not only part of the continental United States, but elsewhere across on an international platform. So with that, let's open it up to some questions, Sean.
Wonderful. And we had a few questions here that even I can answer here. And one I always like to be able to answer one or two here. And that's around the presentation being shared. We are recording today's session, and all attendees and even people who registered and didn't show up, so if you have colleagues that were unable to join us today, we will be sending out a recording of the presentation today, or this week. All right, so now into some of the more substantial questions. We asked during the registration for a few questions that people had coming in. So I'm going to start with those, and we'll go into ones that are in. So I'll just throw it out to our panel and leave it up to you guys on who would be best to answer. And our first one has to do with the encounter data. So we talked about moving it from that 10%, the 10/90 split, to a 25/75 split. And this questioner saying, how is CMS able to do this when, at least from their perspective, there's so many data issues around that blend?
Okay, Sean, this is Pam. I'll go ahead and take that. I think that they have been telling us for years that they want to move to encounter data, and I think that this is a personal perspective on this. It's very costly for them to run two systems. So however long they have to run both a RAPS and encounter system, they're actually paying twice for the same data. And when I say the same data, I mean the data that's going to be used for the same purpose. Encounter data has more purposes. It has more data. So they're paying a lot of money to get RAPS data, which is a subset of encounters. And so they want to push forward as fast and as hard as they can to get to full encounter data so they can save the money they're running on what they consider a duplicative system.
Next question is, how are we going to track different classification of risk members and groups according to the 6 areas? I think that's referring to the split out of the community model.
Well, as always, we focus on the HCC portion, but we have a RAF, a total RAF portion within RevMax Pro that shows all your demographics and disease interactions, etc. We will be building in those models so that we can track them more specifically. Some people recently have asked whether we're going to have indicators on what segment they're in. So we may or may not, depends on what the industry requests are, build those out so that you can recognize them individually. Once CMS releases the methodology whereby we can track that month, of course we will utilize that. But we will have all those segmentations built in so you will automatically see the results.
One just came in. Someone has to log off, but asking if we will be available for questions offline. I think the answer to that is
absolutely,
yes.
Always.
Yeah. Feel free to contact us either directly on email, or also there's a contact us form on our website. If you submit through there, we'll make sure it gets to the right person to answer your question there. So hopefully you didn't log off before we're able to provide that response to you. Okay, so one question here that we have is, and I think this goes when you're talking about the MAO 004 reports, and there seems to be some confusion on the difference between the 002 and the 004, so maybe touch on a little bit, maybe.
Okay, sure. The 002 report shows the plans of all their submissions, what made it through and what didn't. So in other words, the encounter process is a two-step process where RAPS was more of a one-step process. Because the health plans filtered RAPS, you would send the RAPS form in, it would come back the next day, typically, and every diagnosis or diagnosis cluster would have either have an error code next to it or be blank where an error code would be. Those that were blank were accepted, those that were rejected had the error code, why they were rejected. Encounter is way more complex. So you send an encounter in, or a batch of encounters in, and you get a 002 report back, and not necessarily analogous with what you send in. In other words, if I send a batch of 3,000 encounters today, and I get an MA02 tomorrow, that 002 likely won't have anything I sent yesterday in it. It'll have a reply, if you will, accept, reject for what's gone before. And it doesn't necessarily tie to any submission. It just ties to the specific encounter. You know, did this line go, did this line go, did this line go? And when they say, yes, this line went through, all that means is, yes, they accepted the encounter. That's it. They accepted the encounter. And I am talking at a very high level at this, but because there's a lot more information, but okay, they accepted the encounter. Doesn't mean they accepted it for risk adjustment. It just means the encounter passed the edit, and it's now in this big bucket of encounters. Then, when they apply the filtering logic, which again they just finalized in December, and keep in mind we've been sending encounter data in for how many years? So the filtering logic I think only goes back to being over the January 14 data forward. So they take the filtering logic, they apply it to the encounters that they've been receiving with dates of service from 114 forward, and they go, oh, this qualifies based on my logic. Then you get an MAO004 that says, oh, not only did you get into the encounter data bucket, if you will, you jumped from the encounter data bucket into the risk adjustment bucket. So the MAO04 says which of those counters that were accepted on 02 actually are going to filter through to be used for the setting of your risk adjustment payment for the upcoming year.
If you need more information on that, I'm sure we can
yeah, anything you need more information on, give us a call, write us an email, and we'll get a hold of you.
So we have a question here. I'm not sure anyone on our panel has a crystal ball to know what CMS will be doing, but maybe we can sort of look at the tea leaves to see, are they going to revisit the idea of not accepting home visits? Or any thoughts around where they're headed there? They were silent on this letter.
They were silent on the call letter with the administration. This is the last sort of requirements or regulations put out by this administration, because by the time we hear them for next year, it's a different administration.
It's hard to say.
Yeah.
It's hard to say.
But given that they didn't do anything or even mention it, and because the home is a good site of service. There's homebound people, and it would be punitive, if you will, to not allow that. You know, my gut tells me they're going to be allowed. Now, they may put more restrictions on what you have to do with that data or what you can do with it, but I don't think they're going to rule it out as they implied a couple years ago.
Or what type of provider.
Yeah, what type of provider it needs to be to do that. That's correct. Thanks, Sue.
We have a question here. It's related on the STARS suspending of their star rating reductions. And so plans that went on sanction came off but had their star ratings reduced as a part of that, no longer under sanction. Will CMS go back and reevaluate those plans? With anything in the call letter, is that something that you anticipate would be addressed?
Well, it sounds like in the fall, they're definitely going to reevaluate everybody that is on sanction. So definitely we're going to hear more about that in the fall.
Okay. Yeah. So stay tuned.
Yes.
Yes. Yeah, because I think because it was such a big issue that they probably, I would assume, go back and take a look at, okay, because we're changing our thought process on this. Going forward, we know what to do, but what about everybody that, you know, that we left behind?
Exactly.
Yeah, like Sue said, I think it is going to be more of, okay, let's just, you know, get our ducks in a row and figure out where we are.
I think they're thinking about it right now, and well, especially definitely we'll have info in the fall.
Right. But I don't, it would be unfair, not that anything's ever fair, to penalize someone when that, and put them at a disadvantage.
Right. And like you said a few days ago, Karen, if a sanction, you know, there's many different reasons for sanctions. And if it's a minor sanction, you don't want to penalize somebody, bring somebody down to a 1-star plan if they were a 4-star plan, you know. So.
Especially if the sanction had nothing to do with quality.
Yeah. But it's just good that CMS is actually taking a look at that problem.
Exactly.
Yeah.
Question on the MMR layout. Will there be changes to identify the new splits in the community segment?
I'm sure there will be. I mean, whether it's MMR or MOR.
Yep, sorry. That is part of what they're looking at to push out as far as the proposed, you know, how they are going to report this and track this. So from my understanding, it is something that's going to be forthcoming. We just don't know when. Because we know this is a big issue as far as, like Pam said in the presentation, like how are we supposed to know who these members are and where they fall? So, yeah, my understanding is that CMS is going to be looking at this methodology.
Right, and I would look at it with the, I don't think it's in the May software release, but it may be in the November software release, and whether it is a combination of MMR, MOR, or just saying, okay, if they have this, this, and this, it equals that. They have to give plans a way to identify so that we can correctly put members and reconcile demographic risk scores accordingly.
Yeah, and also my understanding is with anything that CMS is, quote, proposing, they are going to push it out to the industry for comments. So everybody will be able to have the ability to see what they're proposing to do and then provide comments, yay or nay, I agree, don't disagree, and whatever. So, yeah, again, that is something that we're expecting to be coming out, quote, shortly. CMS timeframe.
Yeah.
Question coming in, and it relates more to the CIO RevMax Pro product. So asking if our software allows users to compare risk scores based only on EDPS and only RAPS data?
Yes, we do both currently. You can look at it from RAPS perspective, EDPS perspective, and the 90-10 blend perspective. We also have various reports at the member diagnosis and data service level to show you where you have a RAPS, a claim, and no filtered EDPS, or where you have a filtered EDPS and no RAPS. Again, that may be 100% correct, but where it's not, where it's not yes RAPS, yes EDPS, yes filtered EDPS, but we can also provide that as well. But the variances are already built into the system, as well as the weights, rates, etc.
one more question that was submitted, and we probably have time for one or two more if anyone else wants to get theirs in here for the top of the hour, and that's around the mismatch rates and what types between EDPS and RAPS mismatch rates have we been seeing or hearing about so far from clients?
Interesting question. Well, a lot of our clients started way back last year, actually in June and July of 15, looking at mismatch rates. And they started and they were at 40%, 60%, keeping in mind that was a 4 or 6% hit to their revenue because it was 10% of the revenue. But because that blend didn't take place till this year, they have been able to bring it up to where they're extremely close, and the variances anywhere 5% up to 20%, but the 5% could just strictly be a byproduct of the difference in filtering logic. So they're all over the map. If you haven't done anything to reconcile, wouldn't be surprised if you're 40% discrepant and higher. If you're lucky, you're at 20 or 30, but the averages are coming down dramatically when people start working those variances.
So maybe, then if you had a 40% discrepancy, when it was only a 10% split, 90-10, that's one thing you may be able to tolerate, but as they ratchet up to 25% and more, it's going to be a challenge for folks.
Yeah, and we have, again, we have it down to the member level and data service, and we actually even have it down to what kind of provider it is. So that's all there. It's in the application as well as downloadable from the application so that you can work with it within your own system.
Sure. Well, we're approaching the top of the hour here. I'd like to thank the audience and again, Pam, Karen, and Sue for taking the time to join us today. If anyone on the phone here would like someone from SCIO to contact you about what you've seen today, any further questions you may have, you can reach out to us any number of ways, email, phone, or again on the Contact Us page, which actually have a link to on my closing slide here. Contact us and we'll make sure that someone follows up with you. Again, today's session was recorded. We sent out to you in the coming days. We also have a brief survey that will pop up as you exit from the webinar. We ask that you should take that, just a couple questions, help us understand where you are at in sort of addressing these needs that we talked about in the call letter. And with that will conclude today's webinar. Thank you again for your participation. I hope everyone has a wonderful rest of your day today. Thank you.
Thank you.
Thank you.